And so we are asking folks to try to reduce distractions by sending your calls to voicemail, silencing your ringers. Given that we've got about 50 folks on the line, I'm actually going to go ahead and mute all of the callers. If people have called in using their attendee number, which it looks like many have, but a fair number have not, I will be able to unmute you to ask questions, but otherwise you can use the chat function. So again, to ask a question, and you can do it while the speakers are speaking, or you can do it afterwards. I will be moderating. You can use the chat box here to the host and speakers, or I would chat to the presenters actually. And otherwise, you can raise your hand. You can click next to your own name. You'll be able to make a little hand pop up, in which case I can recognize you, unmute you, and allow you to ask your own questions. So today's speakers are Frank Anderson and Sanjeev Arora. I'm going to do a brief little intro of both of them, and then I'm going to hand over the presenting ball to Frank as the first speaker. Frank Anderson has been very active at the Open Door Clinic, which is in Humboldt in Arcata, starting in 1971. And their program there has really grown to include 10 clinics operating from Eureka to Crescent City. Frank himself has been in the Humboldt area after moving there from the San Francisco Bay Area in 1963. Oh, actually moved to Humboldt in 74, sorry, and currently resides in Arcata. He's had a 25-year career in nursing with experience in emergency, intensive care, surgery, dialysis, outpatient care, risk management, and education, kind of everything, it seems like. And he became the Director of Telehealth Development for the Open Door Community Health Centers starting in, Frank, when was that?
2006.
In 2006. Sorry, I'm having trouble reading. My bifocals aren't quite working here. So the telehealth program began there, though, in 1999, and Frank is currently responsible for coordinating efforts to develop that telehealth and visiting specialist center, which you'll hear a lot more about, and promote telemedicine throughout the northern region of California. Open Door joined the Specialty Care Safety Net initiative in early 2010, and that is a telehealth demonstration project that connects 38 safety net clinics across California with medical specialists at the 5 University of California Schools of Medicine. Open Door has also established the Telehealth Visiting Specialist Center in Eureka, which features 14 different local specialists and over 20 telemedicine partners throughout the state. So this Telehealth Visiting Specialist Center not only offers in-house telemedicine consultation for Open Door, but also brings local specialists to consult with patients and primary care providers throughout rural California. So it's an interesting model. In addition, this telehealth hub site evolved from a grant-dependent operation to one that contracts and bills for most of its services. And in fact, Open Door's telehealth operations generate $3.5 million in revenue for the region every year. So, and through that program, they've increased telehealth utilization by over 300% since the beginning of 2007, so some pretty rapid growth. Dr. Sanjeev Arora, who I still will get onto the line, and Sanjeev, I cannot unmute you because I don't have you. I don't have your line linked to your name. So you may need to hang up, dial back in using the info on the info tab, and use the ID number that you have connected to your name so that the phone is actually connected to your name. Right now you're a kind of unknown call-in user number, and I don't know which number you are. So we'll try that, and let me continue introducing Dr. Arora. He is the director of Project ECHO, which stands for the Extension for Community Healthcare Outcomes. He's a tenured professor of medicine in the Department of Internal Medicine at the University of New Mexico Health Sciences Center. He's been involved in the management of viral hepatitis for over 15 years and led the development and implementation of the Hepatitis C Disease Management Program at the University of New Mexico. Dr. Aurora developed the Project ECHO model as a platform for service delivery, education, and evaluation. They use video conferencing technology and case-based learning with primary care providers from rural and underserved areas and prisons to train them and mentor them via ECHO's medical specialists to deliver the best practice management of complex health conditions in their communities or correctional institutions. So a key component of the ECHO model is an innovation known as knowledge networks, in which the expertise of a single specialist is shared with numerous primary care providers through telehealth clinics, thereby increasing the access to care in rural areas without having to recruit, retain, and fund additional providers. So, excuse me. While ECHO was first developed for the management of hepatitis C virus, optimal management of which requires consultation with multidisciplinary experts in medical specialties, mental health, and substance abuse. Project ECHO has since expanded and now covers 12 additional disease areas, including asthma and pulmonary disease, chronic pain and headache, diabetes and cardiovascular risk reduction, high-risk pregnancy, HIV/AIDS, integrated addictions and psychiatry care, and rheumatology. Additionally, ECHO is currently being replicated at the University of Washington and at the University of Chicago. Currently, ECHO projects in India include HIV, autism, and treatment of organophosphorus poisoning. So as opposed to the open door model, which we'll hear about first, and is generally more of a one-to-one approach to specialty care and also includes local specialists, Project ECHO uses a specialist-to-many approach and is clearly based at that academic center. So I want people to have that a little bit in mind as they think about how these models may or may not apply to your particular clinical setting. And so I am going to pass this ball off to Frank to allow him to present, because you've heard enough from me. And Frank, can you grab that? Frank, are you there?
Yeah, I'm here. Do you want me just to advance slides at this point? Or?
Yes, and you can start speaking, and I'm going to put myself on mute.
Okay, I'm trying to advance these slides, but...
Is it not working for you?
Well, I'm clicking on the arrow.
Hi, nothing's happening. I passed the presenter ball to you. Dr. Aurora, I think we can hear you now. You want to say hello?
Hi, how are you?
Good. All right. So I'm going to put both of us on mute and get Frank on the line here.
Here we go. All righty. Very good. I think we're good to go here. Welcome to everybody. As Dr. Chang said, I'm going to discuss our program a little. This is going to be kind of a nuts and bolts presentation, more on project development, a little bit on economics and business models, and perhaps some of this will pertain to you. The first slide really basically is that we're all looking for safe harbors for our patients, and in this case, for us, the challenge was to try to get a safe harbor in specialty care for our safety net patients, and also a little bit of a safe harbor in mental health for our primary care providers that are trying to take care of those patients. The Open Door Community Health Center layout is a little bit unique, and I think that that's important to know in terms of what works for everybody else. We have a semi-urban region, which is Eureka, Arcata, California, where we do have a core of specialists. Certainly not subspecialists, but we do have a core of specialists. We do have several hospitals. Then we have outlying clinics that go into very rural areas. Our clinic system is spread out 100 miles north to south, 50 miles from west to east. And so because of that, we developed our program based on that availability. A lot of clinic systems don't have a rural center. They may have lots of different clinics, but they are all very rural and bereft of any specialty care. So I want to make that differentiation. Now, what we experienced was that we had had two problems. Local specialists, regional specialists, so to speak, in our area were a little unwilling to see our patients. Those are safety net patients, uninsured, Medi-Cal, CMSP patients. And then, of course, we had the further issue that some of our patients were very remote from not only our regional specialists, but, of course, very, very remote to any sort of university specialists or specialists in the San Francisco Bay Area or whatever. So we had that two-pronged issue that we wanted to try to tackle. We became involved with telemedicine as a patient presentation site in 1999 with the original Blue Cross demonstration project, and we're presenting patients out to University of California, Davis, and obtaining that kind of service, but we felt that we wanted to try to ramp that up a little bit and get out of that being at the bottom of the food chain, so to speak, where you're dependent on either grants or availability or project viability at a distant place for all of your specialty needs. So what we of course, I can tell you I don't want to do Telehealth 101, but we realized that video telehealth, both live video and store and forward, would give us options for medical consultations, would be able to give us an ability to do distant patient education, would enable us to have doctor-to-doctor discussions that would not only be clinical but also for business, administrative, because our own clinic system was spread so far. And then, of course, the ability to provide continuing medical education as well between our own clinics as importing it from big sites such as Kaiser or the universities. So we started seeing that as a potential solution, and knowing that trying to find out why specialists wouldn't or couldn't see our patients was also an important part of that, and that was realizing that part of that was the no-show rate and the compliance issues that safety net patients present for specialists. As you know, typical specialty practices experience maybe a 7 or 8% no-show rate, whereas federally qualified health centers and safety net providers often have no-show rates of over 20%. So we realized that we had to kind of try to present a situation to our local specialists that would protect them from that a little bit, to be able to entice a marriage between our local specialists and our patients, and then be able to use live video telehealth to be able to leverage that care out into outlying communities. So we built a telehealth and visiting specialist center, and we did this primarily to, like I said, to kind of have a place where our regional specialists could come in, work with our patients. We absorb the no-shows. We pay them by the hour. They give us 4 or 8 hours a week of their time. We have a number of different specialties. We weren't sure if this was going to work, but we found out that it would, and that folks were happy to try this out, and it seems to be working pretty well. Now, most of that work is live, inpatient. Patient walks in, sits on the exam table, and is seen by the specialist. But we also realized that this gave us an ability to kind of have a centralized place to receive outside consultations, because we're a hybrid model. We not only receive some consultations from university centers, psychiatry, endocrinology, subspecialties, pediatric neurology, etc. But we also are now able to provide and have started providing specialty consultations all over California in the areas where, telemedicine works, where telehealth works, so to speak, the specialties for which it is designed the best, and for the specialties where we have the capacity to share our specialists with the outside world, so to speak. And just as a detail, the specialties where we do offer this to the outside world right now are in behavioral health, pediatric behavioral health, and medication management. So it's not just counseling. We do medication management for peds, and then also in diabetes consultations, both education and, again, medication management, and that is done by a nurse practitioner who is also a certified diabetes educator, not an endocrinologist. We don't have one of those there. We probably won't have an endocrinologist in Humboldt County for a few years yet because that requires a different level of economics than we have in our region. So why did we do this? Well, we're in the position of loving the idea of telemedicine, but also seeing the dark side of it. The dark side of telehealth is that you can create kind of a big box mentality where all the expertise resides in the urban settings and the academic settings, and the rural areas become less and less economically viable. So we wanted to be able to show that if you have a place that is kind of on, in between, that you want to bolster it up. You want to be able to offer this to your local specialists as an interesting format. Specialists love doing a little bit of telemedicine. They don't want to do necessarily 8 hours of it sitting in front of a monitor, but to be able to see patients some of the time and offer some specialty consults is kind of an exciting and a nice variety. And also we have retired specialists who maybe have retired young or for other reasons, perhaps for physical reasons, and still have a lot of brain power that they can use to share. And so we find that there are, it creates a nice off-ramp for specialists in our community to become a telespecialist, so to speak. So it's economic retention. It helps our economy, and that's critical. We are in the luxury of being able to have that available, and we really want to help preserve it, and that's how we're keeping dollars in our region. How we recruit our specialists how we recruit them is by offering them something that works for them as well as working for us. There's certainly a certain amount of wanting to give back to the community, and most of our specialists have always felt a little bit bad about not seeing the uninsured, not seeing the Medi-Cal and Medicare, but so this gives them a chance to kind of deal with that. But that's not really the full story. There's also other reasons for why this works for them. For instance, if they are nearing retirement or are retired and want to get back into the workforce. Or perhaps there's a region of the area that our cardiologists want to kind of cement into their as part of their practice area, so that they have those patients that they can work with that are perhaps a little far away and might end up going, because in our case we're close to the Oregon border and patients were migrating north to specialty care in Medford, and this is an ability for us to keep those dollars in California. We do hire them as per diem employees, and we do insure them with our wraparound malpractice insurance policy, and because of that we have a one-on-one relationship with our specialists where we hire them as individuals. And if they want to put that money back into their practice, many of them do have, of course, practices as well as working with us. That's up to them. And then we absorb the overhead by providing the staff and providing all of that kind of support and handling after-hours calls, etc. If you do hire a specialist as an FQHC and you want to insure them, you do have to do it this way. The payment has to go directly to them. If you want to contract for specialty care and receive telemedicine remotely, then of course, and you don't have to insure the person if they bring their own liability insurance with them, then of course you can contract with corporations and organizations, and that works out fine, and many clinics do that. So what happens when you start working with specialty care? Well, it brings a lot of interesting things. The thing that we realize right away is that just having access to the specialist doesn't solve the problem. Safety net patients, because that basically just means that you just tell the safety net patient a lot of bad news about their health, and now you have to back it up with leveraging, helping them get the diagnostic workups and helping them get other types of procedures done that many times safety net patients have been unfortunately not able to obtain, but also may feel very uncomfortable in navigating. So there's a lot of support that goes when you start hooking the safety net population up to specialty care that you sometimes don't think about. The solution isn't just getting the appointment with a specialist. As a hub site, we really realized a little bit, it was very interesting to realize what it was that our specialists were receiving in the way of referrals from us, because now they became us. So we were receiving referrals from our outside clinics to our specialists, and we realized that there's a lot of issues with cleaning up referrals. And telehealth can be used to cement a relationship between the specialist and the primary care side to try to clean up those referrals and make sure the referrals are appropriate, which can lower the volume of referrals, which can make the access better. Because there is a problem there that is kind of ongoing with especially young mid-level providers who perhaps are kind of in a situation where they don't have ability to consult with senior clinicians, and they send referrals out that maybe could be handled in different ways. So we've used telehealth for educational purposes in this way as well within our own clinic structure. Talk a little bit about the cost of telehealth. If you want to start up a telehealth project, like I said, it really depends on what your situation is. You know, do you have a core of specialists that you maybe want to build a specialty center for and work with? If you do, keep an eye out on upcoming legislation which may change the reimbursement structure to specialists. There is a vague possibility. I know in California everything is up in the air, and so I'm not going to say anything is for sure because of the budget situations, but there could be a change in the way specialists are reimbursed by Medi-Cal, and if that does dramatically change, there may not be so much of a need to lure specialists into your clinic setting, because if they're getting a PPS rate for seeing a patient, that could discourage them. But that's been brought up, but I'm not sure it's making much headway. However, if you want to become a patient presentation site and receive specialty consults, a lot of the equipment is certainly available now in California through a number of initiatives, the California Telemedicine Network Initiative, Proposition 1D. There's a lot of equipment dollars right now for setting up. However, the equipment is just the beginning. There are hidden costs that you need to know about. I've listed on this slide some of the costs of connectivity, the expenses of keeping your internet or your broadband connections low cost by receiving discounts from the state and the feds if you are a nonprofit. Now, if you're a profit organization, then of course you're just going to have to pony up the money for the initial equipment. The equipment is coming down, and it's worth it to shop around and see what's available, and you know, do an analysis of what it is that you really need. Start slow, and you know, work your way up. Let's talk a little bit about reimbursement models around telehealth. As you probably know, telehealth is now reimbursed by state-sponsored programs and commercial insurances to varying degrees. The issue is how, if you're going to enter into a relationship with a specialty provider through telehealth, are you going to what we relied on for years was grants. And grant programs guaranteed you X amount of appointments with a university for certain specialty care. And that's fine, and that was a very good way to get started, but really you can't ride that horse forever. It just becomes overwhelming. There's a lot of course, with grants, there's a lot of paperwork and reporting. And so our goal, you know, is trying to move now towards business as usual. And business as usual in a way that is sustainable. Because if you have a great champion for telemedicine in your program and for years you're doing okay, but that person leaves and all of a sudden the program dries up, well, you didn't have a business model. You just had something that somebody was pushing forward and carrying forward. So I think it's important to look at that and see, you know, what works for you. For us, of course, the goal is to break even. So some of the models that I've listed here, third-party payer reimburses FQHC's specialty site directly, that's what we do. In other words, when we provide specialty care to an outside clinic, perhaps in Chico or in Brawley or in Tulare County or wherever, we take over the patient for that visit and bill the PPS rate directly and build a chart on our end and all like that. We don't charge the patient presentation site any money for our time. We just bill the third-party payer directly. There are other, as well, that side can also put a provider in the room and engage in the consult, and if that's the case, then they can bill for the visit on their side as well. However, you can also, as a clinic, contract with remote specialists in a variety of different ways, and there's a more and more private, for-profit, and the universities now as well, beginning to contract for paid, for time, and under either a pay by the hour, and then the clinic that contracts with them bills for their visits at their PPS rate, or some specialists bill by by the clinic, just a flat rate by the clinic, and however many patients you can put in front of the monitor in a clinic is kind of between you and the specialist, and then as a clinic you get to bill that. Some specialists bill request a portion of the PPS rate, like an agreed upon percentage of the PPS rate as their patient per visit. So there's per hour, there's per clinic, there's per visit. There's a lot of different arrangements. If you're looking at one of these kind of arrangements, the thing I would ask, realize that just as with many things in life, there's the weakest link is the thing you got to look at. So make sure you're ready to, so to speak, do your end of the bargain by having an efficient operation and getting patients in. If you have a very high no-show rate, I would encourage you to worry a little bit about paying by the hour because you are going to eat those no-shows. So those are just some considerations. Sophia, how am I doing for time?
Another couple minutes.
Okay. So if you build it, they will come, and that's true. If you have a successful program, so it's okay to start slow, because if you have a successful program, it will build on itself happily. We've seen that, and our telemed usage is up by 300% over the last 4 years. I visited another program in Reading recently that started presenting pediatric patients for telepsychiatry, and their program has doubled in the last 12 months. Now, did all of a sudden pediatric psychiatric pathology double in the last 12 months? Well, of course not. What happened was that the word got out that this program is working, so primary care clinicians became more comfortable, families talk to other families, and you start building your program. So you can expect that to happen if it's successful. I'm going to just whip through these slides. This is just some of the equipment that you can see. It's best to look for equipment with small footprints. Equipment that is mobile may work for you. It depends. There's good and bad to mobile equipment, but a small footprint equipment is just, generally we just don't have that much room in our clinical space. This is a provider station. Here's a picture of our psychiatrist seeing a patient. So you can see, and this monitor is a double feature monitor, so she can push a button and it turns into her computer monitor. So again, there's desk space is conserved, and we found that very helpful. On the patient presentation side, you can see that it's really just a comfortable room. Putting telemedicine equipment into exam rooms is sometimes problematic because exam rooms are very, very valuable. You can do a lot of telemedicine, or telehealth is very cognitive, so it's just a discussion. So multi-use rooms can be very useful and less expensive to outfit than an exam room, and you're not competing for exam room space. High definition, of course, is the way to go. And then these are mobile carts that can be moved around. They're useful in acute settings, acute health settings, ICUs, emergency rooms. There's robots now that, of course, are much more sophisticated than this that you can look at for acute care telehealth. Retinal cameras, are a good way to do some disease prevention. There's some new retinal cameras out that are much better than my experience with them is get one, if you can, look at one that is self-adjusting and self-focusing. Some retinal cameras can demand a lot of operator expertise, and that may become a little bit of a problem at your site. It's just something to think about. There's always a new generation of stuff coming out, but here you see retinal scanning going on. You know, a good way to start in telehealth can be just store and forward dermatology. If you can contract with a dermatologist and buy a $300 retinal or digital camera and get an agreed upon software to move the images and the consults back and forth, that's a low investment. That can help you. And so that can be useful. Here's just a wrap-up of the specialties that we currently have available at our site. And that group expands from time to time. So I would just encourage you to look at this. It is happening. It's going to keep on happening. It's just the price of gas and the number of people on the planet and the way we're laid out really leads towards telehealth. And it's better to take the lead rather than be kind of squeezed into it. And it's already here. Here's a picture of the redwoods above my house. But when you take a really close look, one of those redwoods is actually a microcell tower. So with that, I'll wrap up here and pass the ball back. Hello.
Hi, thank you. I'm going to take the presenter ball back and give it to Dr. Aurora. And Dr. Aurora, you are now unmuted so everyone can hear you. And if you see at the top, there's a slight delay, but you should now be able to, in the kind of top right-hand corner where that 01 is, there's some forward and backward arrows. You should be able to drive your own slides. Do you want to give that a try?
Yeah, I can see. I can drive my slides now, but I still have Frank's slides up, so.
Okay, click on Echo Presentation.
Got it. All right.
And now you have your own. There you go.
All right. And then should I get started?
Yes, go right ahead.
Well, thank you, Sophia, for the opportunity. And ECHO stands for Extension for Community Healthcare Outcomes. And it's not moving.
So it's not working when you click to the right?
No, it's not clicking forward. Can you do it? Or
I can take it back. Here, I can do it for you if you want.
I want to try it myself, because I'm going to move very fast through it, so it'll be good if I have it.
Okay, so it'd be better if you did it. Here, I just gave you the presenter back. So, so that little teeny little arrow to the top right is not working?
Yeah, when I click it, next page, when you hover over it, it says next page, and then I click it, nothing happens.
What do you, So clicking, nothing happens. So something must not be working. So,
how about you want to move it?
I'll go ahead and move it, and you can just say next slide, and I'll do it. Okay.
Next slide.
You know, it's not working for me either.
Okay. So I think you just need to reload it up, I guess.
I guess. No, the problem is that my assistant, I don't know if she's here, can do that. Let me do this. Why don't you start talking about the program, and if nothing else, I will see if I can find the slide set you sent me and just show my desktop. Oh, someone's saying maybe Frank can move the slides. Frank, maybe I'll try you. Frank?
Yeah, I'm trying.
Is it, so it's probably his slide set then, right? You can't get it to forward either?
No.
Okay. All right. I'm sorry about this, everyone. This is why we had tried to get on earlier, but we didn't quite succeed today. So, hold on, I'll find this. So, Dr. Aurora, why don't you go ahead and talk about your program, and I will start pulling up this other slide and see if I can show my desktop.
Okay, 1 second. Let me pull up my slides too a little bit. 1 second. So the mission of Project ECHO is to bring care for common complex diseases, best practice care for common complex diseases to underserved populations. And what I'm going to do is I'm now pulling up my slide deck in a moment here myself because I didn't expect this myself. So give me a moment.
Oh, actually, we can see your PowerPoint.
Who can?
Yeah, so why don't you just show that on display?
The one that I have here?
Yeah, so we can see your desktop and we can see your ECHO project slide within PowerPoint.
Okay, so let me try to project it right now.
Yeah. Oh wait, maybe that was, hold on, maybe that was mine that I was showing. Hold on.
Here, okay, now I'm loading up my PowerPoint on my.
Yeah, can anyone else see that or no? Craig, can you see it?
Can anybody see my PowerPoint now? I'm moving it back. Can anybody see mission?
No, they can't. Hold on. Let me see if I can get mine to show. This is very frustrating. Hold on.
I'm happy to do it another time because we're running out of time and I don't want to...
I know. This is very disappointing.
I don't want to take away from Frank's Q&A and everything. It might be... Should we just do it another time?
Hold on. Let me see if I can do... Let me see if I can... if you go... Sanjeev, go to the top and under share, so click share presentation or document.
I go where now?
At the very top, there's the little blue, line, file, edit, share. And under share,
yeah, okay. Yeah,
presentation or document, try that.
Okay.
And let's see.
Okay, I got it now, okay. I think now that I see this, I might be able to do it because it looks like I looks like I'm in the right place now, and I think I should be able to share it.
Let's see if you can share. In which case, then hopefully you can drive from there.
Yeah. Okay. Now you tell me if you see it. I'm saying share right now, and it's.
Okay. You don't see it yet.
It should be. I think something is happening right now. So let's see. Do you see it?
Yes, I see a different tab, so now try advancing that.
Okay, now you should, do you see my desktop at this point?
No, I'm just seeing the...
Do you see a slide that says mission on top?
No. No, I just see, okay, now I see another ECHO tab. Do you see a new ECHO tab? My assistant may have reloaded it.
Yeah.
Try the new ECHO tab and try driving that.
Okay, let's try driving this one. Yeah.
Okay, there you go.
All right. Can everybody see it now? Can you see it?
Yes.
Okay, perfect. I'm going to speak very fast, okay? So the mission of Project ECHO is to expand the capacity to provide best practice care for common complex diseases in underserved areas and to monitor outcomes, funded by ARC, by Department of Health and Robert Wood Johnson Foundation. It started for hepatitis C, where we have 28,000 people in New Mexico with the disease. Less than 5% had been treated, and we anticipated without treatment 8,000 would develop cirrhosis, many thousand would die. There were 2,300 prisoners, none had been treated, and we have the highest rate of chronic liver disease cirrhosis deaths in the nation. The good news about this treatment is it's curable. 45 to 80% of the time, new drugs were released last month, which now have taken this cure rate from 75 to 80% of all patients with hepatitis C. There are serious side effects, however, and no primary care clinician was treating hepatitis C in New Mexico out of more than 3,000 doctors here. Because of severe side effects, 100% people develop anemia, a quarter depression, and a third neutropenia. And New Mexico is a very underserved area. 32 of 33 counties are medically underserved. 14 are health professional shortage areas, and only 20% of our doctors practice in rural or frontier areas. So we developed a new model to develop the capacity to safely and effectively treat hepatitis C in all areas in New Mexico and to monitor outcomes. And we said if we could do that, we'd have a model to treat complex diseases in rural locations in developing countries. We developed a partnership between the university, corrections, health department, Indian Health Service, and community clinicians. And this is the most important slide because the project is based on 4 key principles. First, we use technology, multi-point video conferencing to leverage scarce healthcare resources. We use a disease management model based on quality improvement principles of Deming, that we create a best practice protocol and essentially share it with everyone on the network. Case-based learning is saying that when doctors learn, they learn by doing with mentors and professors, just like they learn during their residency and fellowship. And if they're practicing in a rural area and you expect them to read books to treat hepatitis C, that's going to be hard. So we said we could use technology, video conferencing, to bring case-based learning into their lives. And we track outcomes on the internet. We train these physicians, nurses in hepatitis C, train them to use our web-based software called iHealth. We conduct these telemedicine clinics called knowledge networks. And we initiate, let me just show you how a knowledge network works. So this is a knowledge network in action. On the left big screen is our team of a psychiatrist, me, my nurse sitting there. And first, on the top right, Espanola will present a couple of patients with hepatitis C. Then we'll go to Pecos and Las Vegas, and in a 2-hour session, we'll co-manage about 15 patients of hepatitis C from all these different sites. And also we'll give them a brief didactic presentation on some aspect of hepatitis C, which lasts about 15 minutes or so. And that's the knowledge network. And the way these clinicians learn is through learning loops. They learn from the specialists, they learn through didactic presentations, they learn from each other, and they learn mostly by doing. And then we collect data. We give them no-cost continuing medical education credits and nurses credits for participation, and we want to reduce their professional isolation in rural areas and give them access to multiple specialists at the same time. We have a video conferencing bridge which can allow up to 80 participants at the same time, and we have recording devices so they can come and watch these lectures synchronously. They don't need a sophisticated camera like a $3,000 to $4,000 camera. They can just have a webcam, and that should be enough for them to interface with us through this equipment called Polycom CMA 5000. We've done 500 such HCV clinics, more than 5,000 patient consultations. We've provided overall more than 15,000 hours of of CME credits at no cost to rural or prison clinicians. So the first thing we measured was self-efficacy. We know that the doctor is not going to treat hepatitis C unless they have the self-efficacy to treat it. So we asked 25 of our first hepatitis C clinicians, what is your ability to identify suitable candidates for treatment? And the range here was scale is 1, no skill, and 7, I'm an expert who can teach others. And these primary care clinicians were 2.8 out of 7, went in 1 year to 5.6. Question number 3 is, what's your ability to treat hepatitis C and manage side effects from 2 to 5.2? The principal goal here is not just to manage the patients of the primary care clinician, but to have them serve as a local consultant in their area for hepatitis C questions and issues. And you see question number 5 goes from 2.4 to 5.6. Overall competence from 2.8 to 5.5. We know that a primary care clinician is not willing to spend time just because it will make them confident to do something. It should be beneficial. These are 35 clinicians. We asked them, is enhanced knowledge about management and treatment of hepatitis C a benefit to you? 97% felt it was a moderate or major benefit. 94% felt being well informed was a benefit. 98% achieving competence was a benefit. In 2005, we did a survey of 17 partners at that time. Has diminished my professional isolation, 4.3 out of 5. Enhanced professional satisfaction, 4.8 out of 5. Collaboration among agencies, a benefit to my clinic, 4.9. Expanded access to treatment in my community, 4.9. Access to specialists in general is a need in my community, 4.9. And access to specialists, HCV is a need, 4.9. Finally, we did a hepatitis C trial. This was funded by Agency of Healthcare Research and Quality. The objective was to train primary care clinicians in rural areas to deliver hepatitis C care in prisons and rural areas to show that such care is as safe and effective as a university clinic and that we can improve care for minorities. There were 16 community clinics in 5 prisons. The control was the University of New Mexico Liver Clinic. Every consecutive patient that met the inclusion-exclusion criteria was enrolled. The principal endpoint was the cure of virus, a sustained viral response. A sustained viral response in hepatitis C means that 6 months after we stop treatment, essentially what you find is that the virus is not there. And that's a cure. Even after 15 years when we check, it's not there. And even if people have early cirrhosis, it goes back to normal. So here are the results. They were published in the New England Journal of Medicine on June 9th, just a couple of weeks ago, showing that of the echo sites, 68% were minorities versus 49% university. So we met our goal of enhancing access to minorities. The cure rate was genotype 1 was 50% in echo, 46%. Genotype 2 and 3, 70-71, no difference. In conclusion, was that rural primary care clinicians deliver Hep C care that is as safe and effective as a university clinic, and we can improve care for minorities. Now, before we started this project, there used to be an 8-month wait to see me in my clinic for hepatitis C, and people would have to drive 250 miles, would have to come 18 times for one treatment of genotype 1 infection. Now, there's a 2-week wait in all parts of New Mexico as a result of us setting up 21 treatment sites all over New Mexico through this model. After hepatitis C was successful, we were asked by primary care clinicians to start other diseases, and we felt that if the disease was common, management was complex, new treatments were coming, high societal impact, serious outcomes of untreated disease, and if we can improve outcomes with effective treatment, we could use this model. Here, what I want to show is that through using this model of best practices, case-based learning, and technology, we can cut horizontally so that the same level of care is provided at a community health center as is provided at a university. And the Pareto's principle says that this is the 80-20 rule. What this means is that a small number of diseases account for most of the morbidity, mortality in any community, and we don't need 1,000 echoes. If we just have an echo for 20 diseases, you're going to have a huge impact on healthcare. The principal goal of Project ECHO is what we call a force multiplier. It's something I've defined as a logarithmic improvement in capacity of care, 10 times improvement in capacity of care for complex diseases. And this happens if you can have a nurse practitioner, physician assistant, or primary care doctor provide the same level of care that a specialist would, you get a force multiplier. These are all the diseases for which we actually have echoes now. Hepatitis C, cardiac risk reduction, asthma, rheumatology, chronic pain, substance abuse, high-risk pregnancy, HIV, psychotherapy, antibiotic stewardship, palliative care, etc. We have 298 sites all over New Mexico for all these different diseases. I want to give you an example of a problem that many primary care clinicians face, and another force multiplier is this problem of integrated addictions and mental health. In New Mexico, we have a huge problem with heroin use. There were only 30 doctors out of more than 3,000 in New Mexico who were certified to prescribe buprenorphine, which is Suboxone. And so this is a game changer in treatment of heroin addiction and codeine or pain pill addiction. So we have trained and certified another 175 of these clinicians. These are all the sites we have set up all over New Mexico for integrated addiction treatment, which is manned by a psychiatrist and an addiction specialist. And this is what a force multiplier looks like in this disease. The red line is the number of doctors per million population all over the United States. There are 153 million people in the United States that live in low-income households. And on average, they have 50 doctors per million population in those zip codes that can prescribe buprenorphine because you need a separate DEA number from the feds. And in blue is New Mexico. The green vertical line is when we start ECHO. You can see in New Mexico now we have 120 per million population. This is zip codes in the United States which are rural, low income, and Hispanic. On average, they have only 15 doctors per million population with the DEA number to prescribe bup. And here we have about 120 now. So 6 times greater than the rest, 8 times greater than the rest of the nation capacity to treat this disease. The other point I want to make is to achieve a genuine force multiplier, it's not enough to train doctors. You need to train community health workers, medical assistants, nurses, so they can be part of the chronic disease management team. As we say, chronic disease management is a team sport, and if a doctor doesn't have a diabetes educator or a substance use counselor, it's not going to help. So we have also an ECHO community health worker training program for 3 problems: diabetes, substance use disorder, and we have a prison peer educator program. I'll give you an example of one of them in the interest of time. Essentially, perhaps I'll tell you a little bit. I'm ahead of time, so I'll take a minute to explain one of these programs to you. I'll tell you a little bit about our diabetes program. What we do is we know in these rural areas, these rural doctors tell us they don't get the same A1C levels because they don't have the certified diabetes educators. So we took community health workers who are high school graduates. They are working either as CHWs or medical assistants, nursing assistants, and we asked them, we brought them into Albuquerque, gave them 3 days of training on things like diet, exercise, smoking cessation, finger sticks, foot exams, and then we send them home with webcams. And every week they join in and they get additional training, and they present patients, just like I described for doctors earlier. These community health workers present patients to our expert diabetes educators and nurses, and they get more and more training, and what we found is they become experts, and we've got 75 of these now working all over New Mexico. We have substance use disorder CHWs. The prison peer educator program is another community health worker in prison program, because we had a huge problem with hepatitis C in the prison. And we started checking every single person going into the prison for hepatitis C and found 40% of them were positive. And they didn't know about hepatitis C. They were giving it to each other. We were seeing acute hepatitis C there. So we decided to train prisoners to become teachers there. And this is the first cohort that graduated. We gave them 40 hours of on-site training. Then they sign in every month with us on a video conference and get more and more training. And they present their cases their questions that they got from their students. We have trained 150 of these peer educators now, and who in turn have gone and delivered a 10-hour curriculum to more than 2,000 prisoners all over New Mexico in the prisons. So the potential benefits to the health system for such a model are improved quality and safety, rapid learning, and reducing variation in care. So for example, we had a huge epidemic of H1N1 in New Mexico. Every ICU in every rural hospital was full, and the ventilator settings were different that were required to manage these patients. So essentially what we did is we set up an echo, urgent echo, and in 2 weeks we trained every clinician in New Mexico in every rural hospital on how to manage H1N1 pneumonia. Improving access for underserved patients, workforce training and force multiplier, improving professional satisfaction, retention, we have shown you data, supporting the medical home model, cost-effective care by avoiding excessive testing and travel. In 2009 alone, the number of patients that were presented to Project ECHO saved about 539,000 miles of travel just for those patients. When we do surveys, we find that the actual impact of ECHO is 5 times that, because of the reason that doctors only present 1 in 5 of their patients, and then they become experts. They don't present them at all. Preventing costs of untreated disease, and then integrating public health into the treatment paradigm. This is the team that has done the work, so I want to recognize them so that nobody gets the idea I did it. I want to recognize them by sharing some of the awards they have received. In 2007, applications were sought for disruptive innovations in healthcare, new models that would change healthcare nationally and globally. And our project was selected a winner among 307 applications from 27 countries. And this was sponsored by RWJ, and they gave us a large grant as a result of this victory. There were several other awards over the years, which I've listed there, and I won't talk about them right now. In conclusion, using multi-point video conferencing, best practice protocols, co-managing patients with case-based learning, which is the ECHO model, is a robust way to safely and effectively treat chronic common complex diseases in rural and underserved areas and to monitor outcomes. And I want to thank the funding agencies, which are Department of Health, Agency of Healthcare Research and Quality, the New Mexico Legislature, and Robert Wood Johnson Foundation. Thank you for your attention. I'll stop here.
Thank you, Dr. Aurora. We have a couple minutes for questions. I'm afraid that due to our problems on our side with technology, I apologize for cutting off the time for questions. I do see one here that was posted on chat, which was asking as to whether or not there's a resource where we can find the current reimbursement rates for telehealth services.
If I could, what I responded to was it's a PPS encounter if you're a federally qualified health center. If you want to know, in terms of fee for service and what other carriers are reimbursing, I think that opens up, that's a whole lot of different things. But for state-sponsored programs, we use the CPT codes that correspond to initial visit or follow-up visit, but because we're a federally qualified health center, it comes through at our PPS rate. Another resource is CTEC, and they are the regional agency for support agency for telemedicine for California, for actually more than California, and I listed their phone number.
Great. So there's two other questions here. One is to Frank or Sanjeev. How have you used telemedicine to provide supervision to mid-level practitioners in rural clinics? So supervision of those mid-levels by physicians.
Yeah, so we don't, we have not, in ECHO we don't do that. In ECHO we basically train these mid-levels. We have hundreds of mid-levels participating in ECHO, and we have them choose an area of interest and we make them as good as a specialist. That's the model we use, not a supervision model. We use a model where we make them as good as us so that they get supervised by their own doctors in the rural areas. But our purpose is to give them the expertise they need to provide the best practice care in their communities.
And Frank?
Well, I guess, you could kind of think of it as, could you use telemedicine to substitute for the traditional PA, especially PA supervision relationship? Nurse practitioners are quite a bit more independent, but the PA delegation of services agreement does require a supervising physician. I suppose you could explore the use of telehealth as the mechanism by which that happens. I mean, we have, we haven't actually tried that because we don't have any clinics where we just have isolated mid-levels and no medical doctors at all.
Great. And we're running a minute over time, so I'm going to ask one last question briefly of each of you. What do you think about using Skype for conducting the telehealth conference? Have you tried that, Dr. Aurora?
The way we work is Skype only allows up to 2 or 3 people at one time, and that doesn't work for us because the principle of the conference is to train huge numbers of people through the case conferences, and they learn from each other. So we need more sophisticated technology which allows 15, 20 people to come at the same time, and Skype is not robust enough for that.
And Frank?
Well, the problem that we've run into is opening our firewalls up to Skype because our IT department is very nervous about allowing Skype calls into our network because that's kind of a breach of the firewall. And so what you're running into here is, HIPAA concerns and encryption. I mean, technically it works fine. That's not the problem.
All right. Well, thank you, everyone. Again, I apologize to all those on the call for little hiccups with technology, but both of our speakers, both Frank Anderson and Dr. Sanjeev Arora, I think have been fabulous. So I want to thank everyone for their time and energy, and especially to the two of them for their wonderful presentations. We will be posting the recording and the slides within the week at our website, which you can see hopefully on your screen. And thank you, everyone. Bye-bye.
Bye-bye.
Bye-bye.